clothes, you don't lose all the characteristics of the reach of the patient. So here I place one implant here, one implant here, and I graft in between the two implants. You don't see the tissue, you don't see the healing abutment, you don't see how much soft tissue was created. And once we went to the lab, we did our wax up and pushed the tissue around. Okay? This 3 millimeter implant active, and this 3.5 millimeter healing double active implant. You can see how much I have to push the tissue in order to create the scallop you're gonna see, and this is what we call confining the soft tissue. The problem is that we don't have a tight base on the 3.0 implant double active, so the zirconia is bonded to a titanium abutment. So I would like to share with you my thoughts and things that are totally different from what you see or what you read. So I have 2 implants in here. I did 2 single implants. The late mode is difficult to have a connective tissue in between. The crown, veneers. I did a bleaching here, internal bleaching and a crown. I have 1 tooth in between 2 implants. So let's look at this case. This 1 year follow-up. This crown, implant, veneer, crown, bridge, posterior implants with connective tissue, internal bleaching and composites. Here, connective tissue and implant, tooth. What I'd like to share with you is what happened on time. So this is a case that we wrote in 2018, and it shows all the steps that we did. We did connective tissue graft 2 times to get to this result. Connective tissue graft on the tooth is 4 years down the road. This is about 4 years. The teeth are start moving, extruding. Okay. The papilla is very much in its place. This is 2015 against 2022. My patient has a cancer. She has been radiated quite a bit in his head, so maybe she has lost some volume. She's doing good so far. But I would like to share the papilla height. You can see the teeth has extruded. So the papilla has extruded on both veneers. And you can see that your maxilla always grows down and back. Okay? But what I would like to show you is radiographically what's happening here. You can see on the posterior there is no contact points and the tooth intruded. Okay? So those are questions that nobody is able to answer. But you can see that the tooth intruded around 6 millimeters. So going back to the anterior teeth, I want to show you where I place the implants, how much pressure I created with my abutments, and all that bone is totally gone. Okay. 7 years down the road. Okay. So today, when I have especially grafted the site and placing implants, I don't do this anymore. Because we know that if you use transmucosal abutments, we help on reducing the pre-implant crestal bone loss. And there are many articles showing that, and those articles are telling you that the shorter the transmucosal, the more you will be losing bone, the higher the transmucosal. I'm talking about 2.5 and 3.5 millimeter high. Okay? So let me share with you this case. This is a case, central incisor and lateral incisor, same case than before. And we're going to do bone grafting, we're going to place the implants, and I'm going to use the transmucosal as part of the implant. And you will see what I mean by that in a moment. And then we will splint the prosthesis as we always do on anterior areas to avoid movement of the implants and diastema. So in this case, we use the soft lamina from osteobiol, which is denser lamina coming from pigs. And we love this membrane, and I use the pins from this one. I use Endogain, and this is the suture I use. So let me show you the case. This is an accident. She's coming to visit me after she's coming from the hospital, and there is no bone on the central incisor, and the lateral incisor is totally off the ridge. So there is no doubt that we need to do bone grafting to overcome the problem. If you look at the CBCT, you can see that there is no bone on number 11, and there are some bone, but we have lost height and volume on number 12. So I could place some implants, but I still missing a lot of bone height, and it will be difficult to come up with something that looks nice. So the treatment plan here is to extract both teeth and at the same time improve the soft tissue. So we can have more gingiva, because there are many surgeries that are coming, so the more tissue I have, the better. And then I will do vertical and horizontal GBR. I will use 50% autogenous, 50% xenograft. Then I will wait around 6 months, place my implants with tuberosity connective tissue graft, which will be crestal. And then I will show you the soft tissue manipulation with the provisional and the final result. Okay? Sorry. So this is where we started. And I took the soft tissue and I grafted as much as possible to come up with a certain volume. Usually in these cases, there are many things that need to take into consideration. First of all is what type of provisional I'm going to deliver to this patient. And it's an issue because I have to do bone grafting and place implants and tissue grafting, so it's going to be a 1.5 year case. So usually in those situations, I always deliberately place orthodontics. The patient had orthodontics in the past. And what I do is I place 2 provisional restorations with some wire, with acrylic that is resting on the palatal aspect of the adjacent teeth. I hate removables. And then what I do is I place orthodontics on the buccal aspect, just for provisional purposes, to maintain those teeth that are on top of the ridge. Okay? So you can see there is a lot of volume missing of bone and tissue. So what we want is we're going to do the bone grafting. This is the amount of bone grafting. The incision is from the buccal, only one releasing incision. We're going 1 to 1.5. And we have primary closure. This is how much we were able to graft. This is number 11. This is the proximal bone, and this is number 12. So the healing goes along. You can see that those teeth are just holded by the orthodontics, which is the purpose of the orthodontics is to hold these teeth, and is resting on the palatal aspect, like if it was Maryland, is something that I like to use quite a bit. And then this is about 6 months of healing. You can see all the pool of the soft tissue. There is a little bit of gingiva here, not too much keratinized mucosa. So you can see it here, not much. Bone-wise, we have enough bone, but we are lacking of soft tissue. We need to improve the soft tissue. I will do it the same day of the implant placement. So you can see here the planning, how much bone we have. We have the minimum to place our implants. In both teeth, you can see we have more volume of the lateral incisor. So the thing here is we're going to use the transmucosa because we want to avoid losing interproximal bone between the two implants, as you have seen in the case before. So we're going to use multi-unit abutments, and the problem with the multi-unit abutments is if I want to graft crestally, those healing abutments are huge. They wouldn't allow me to really be able to graft on the crest. So what do we use is those guiding pins. The guiding pins here will help me to really be able to graft on top of the multi-unit and being able to have more tissue coronal to it. So this is surgery. I like to place my stent and have an idea where the implants are going to be placed. So I stain it with the stainer and have an idea where the implant goes, and then I place my incision buccal of that position. Okay? So I know where the implant goes, just here and here. So I will go buccal to that incision. Okay? And then I will elevate my flap. I will go a little bit faster because elevating a flap is not such a big deal. So usually what I do is I do my soft tissue management before I do cut my periosteum in order to loosen my flap. And no vertical releasing incision now. So you can see all the tissue is tension free, and what I have learned from Massimo Simeone is to control the hematoma. And one of the ways to control the hematoma is to take a gauze and squeeze it for 10 minutes. Okay? In this way, the bleeding, you stop the bleeding and you have less hematoma. Then I will place through my surgical guide my implants. Not a big deal. I suture away my flap so I can go through it without damaging my flap. I place my two implants. Okay, and then what I'm going to do, as I told you before, in any grafted bone site, I always deepen my implant around 2.5 millimeters. This is something that I learned the hard way. But everything that I graft, I deepen my implants into the bone. I touch a little bit my bone in order to place my, you can see some of that is bone, some of that is tissue that will become maybe bone or maybe not. Some granulation tissue, some bone, in order for me to place my multi-unit abutment. So the multi-unit abutment is going to become part of my implant. Okay? And the multi-unit is going to be placed leveled to the buccal bone of the tooth I want to copy. Okay? So it's a totally different concept than the word of multi-unit is just in between the tissue. Here, the multi-unit becomes part of the bone. Okay? In this sense, I will be always working above the implant head, so I won't have any type of contamination of my implant head. And what I will do is really be able to see how much tissue I can grow on top. So you can see I will gonna deepen a little bit more. It's about, the line is 3 millimeters, so I will deepen it a little bit so my multi-unit is flush almost with my buccal bone of the adjacent tooth. Okay? So I place it there, I modify my soft tissue, and then of course the lateral incisor need to go a little bit deeper. They cannot be at the same height, of course. And then what I use is these guiding pins, which are in titanium, and I cut them pretty much around 5 millimeters or so. I just cut them, make a trough, and I will use these guiding pins as slim abutments. Okay? So in this way, I will be able to graft crustally on top of my multi-units. I love to use laser, because with the laser I take all the tissue out, make sure I have enough space, I refresh the internal part of my flaps. So those flaps that have been contaminated, everything is refreshed against the teeth. So once I adapt everything, and once I adapt my flap to the graft and to the adjacent teeth, I have a pristine soft tissue which will have a better bond. So I make a trough, and I just screw it in, and now I have all the space to grab what I need the most prosthetically, which is crystal. Okay. So what we're going to do now is I'm going to, the connective tissue from tuberosity has already been taken, and I will take the thicker part of the tissue and I will graft it in the middle. Okay? So I just do it in front of the video so you can see how we tailor the soft tissue. I check the thickest tissue where I want it. The tissue has been deepened. I place 15C. I rest on top of my healing abutment and I go up and down. So I cut it and then I go through the healing abutment. Okay. So you can see it has been deeper into endogain. You can see it's alive, it's really wet. It's important to wet your connective tissue. And then you modify where is the thickest part. The thickest part you want is in between the two implants because of the papilla. We have already the bone that will hope it will stay there. The Z characteristics of these anodized surface chemically improved will help for a nice bone ring. And here is the second layer of connective tissue, which will be grafted against the teeth. Okay? It will be crestal, but I would love to graft my soft tissue against the tooth, so I'll use the suture around the tooth to push the tissue against the tooth one side and the other, and stabilized by the two slim healing elements. So it's a totally different approach that you have been taught. It's a totally different point of view, but what we want is just to look at the final result and then just decide what would you do. So you can see how carefully we position everything in place to really be able to suture the soft tissue exactly where we want it. So this is now just the positioning of the soft tissue, firstly, and how much we want the papilla to be improved in between the two centrals. Now that we like everything, we take all the blood off, we squeeze it, and then what we're going to do is we're going to clean, of course, the adjacent teeth, use BTA, and then what we're going to do is we're going to suture into place the position we have decided on this first connective tissue. This should have been done beforehand, but I forgot it, so I did it at the same time. And now what we're going to do is going to start from the palatal flap, going over my connective tissue, punch it, and then go to the buccal periosteum, or the inside part of my flap, and just come back to my palatal aspect and suture. Okay? So basically what we are doing is we are squeezing the soft tissue against the bone. So once you have done the mesial, you go in the center, go forward a little bit. Once you have sutured very much the first layer, then you go around the tooth, and you take the mesial, take the distal, take the buccal, the palatal, and then you suture around the tooth. So basically what you are doing is you are squeezing the tooth, the soft tissue against the tooth. Okay? And suture, so the tissue will be squeezed against the adjacent tooth. Okay? And now we do the same for the posterior. Okay? And then once we have everything done, we close the flap on top of everything. In this way, my flap will be closed tension-free, and I will have my best adaptation of the flaps. I will have tension-free flaps and be able to have the tissue where I want it, as crystal as possible, and I have the volume that is necessary to create my papillas. Okay? So I'll do the same. I just go around my buccal from palatal. All the stitches are outside my flap, and on top of that I suture basically the lip on the crest. Okay? So this looks like that 4 months down the road. The problem now is that the patient tells me, you know, I feel funny because my lip is sutured to the ridge. And I say, yes, your lip is sutured to the ridge. I know that, you know, in order for me to close it, it's impossible to not touch your lip, so we'll need second connective tissue. We'll do a strip gingival autograft in order to bring you, place the lip where it belongs, recreate vestibular depth, and recreate and blend the mucogingival line, because everything that we have here is awesome. Please notice that the bone is being leveled, the bone stays with no problem with this type of analyze surface, which we have had great results and we have cases done that way. So this is the strip technique. This tissue, this regingival graft is taken from the lateral aspects of the posterior teeth. So in this way I have the same color than the anterior. Usually I create a bed, I replace the lip where I think the vestibule will stay. It's important to just suture the lip against the periosteum. Usually I use a PFE 4 zeros to make sure that I go all the way down and suture it. If you don't suture well the lip, all you have created will disappear, as I've shown you in other cases before. And then it's the artistic part of trying to blend and having all the tissue in between is going to take the genetic color of the tissue you have sutured. The most important here is that you need to suture against your bed really well, because if you have any hematoma in between and it's loose, it will necrose. Okay? So all the genetic information will fill all of these in a matter of 2 weeks with gingival graft. This is 2 weeks, looks beautiful. You can see that now we have to take all the stitches. This is 7-0, this is delicate. And now it's a matter of this blanching because of the anesthesia, because now I have to take an impression of the multi-unit and try to place a provisional restoration and start pushing vertically my soft tissue. This is not easy to create, so basically the problem we are facing is that I want to go from here to here, to my provisional. And we don't go straight to the provisional. When it comes to temporary abutment on top of multi-unit abutment, within Nobel we have the snap and the conventional, which is the difference. This has a snap capabilities that goes on the hexes of your multi-unit. This one is totally empty, so we don't use this one. We only use the snap one. And when I ask my technician is to get rid of all the outside ring. Okay. So it's a delicate way of being able to remove all the collar. And then what he does, it makes just a composite customized abutment, which is smaller and and the total diameter of my multi-unit abutment. Once I have created an ideal entrance for my provisional, this will stay just 10 days. Then I jump into my provisional restoration. Okay? So this looks like this. Okay? And we started from this situation to this one. And what we're gonna do is I'm going to use the same impression copy. I take I want to make sure that I have a perfect adaptation of my provisional. So I do with burrs, I do a verification jig with some burrs and pattern resin. I take out only the screw is holding the tube, as you can see here, and we check that the screw is touching the apex of my multi-unit. And what he does is, once he has the provisional, he starts creating the ideal emergence profile, trying to copy the same festoon on the contralateral teeth. He makes silicone index because it's not anti-rotational, it's rotating. So you can see that it's smaller than the diameter, so it's rather easy to place it into the mouth by squeezing and blanching the soft tissue. And you can see how much pull of the soft tissue is provided. And we're going to remove all layers of these orthodontics. The patient is going to be able to clean for the first time. We keep it just for 10 days, and the patient is coming back. We reline the same provisional, and this is about 10-15 days later. So you can see how the tissue creep back to the space. So we still have the papilla, and now it's a matter of to jump to the provisional restoration and have a nice polishing contact. The patient is able to clean for the first time. This is the day of the provisional placement. You can see the black spaces are a little bit open, so the tissue can grow the way that he wants. Usually I wait 3 months before I take the final impression. Okay? But please notice that the bond stays there in between the 2 implants. It didn't go away, and he won't. Okay? So you can see tissues maturing as we go forward, and now it's a matter of finishing the case. This is before the final delivery of my crowns. This is the wax up. This is the papilla. It looks like plastic. And the final result. This is where we started, where we finished. It's on composite to level the soft tissue. This is the iPhone video of the final result. So you can see it's not easy. So this is where we started, where we finished, and you can see the stability of the bone. Okay? You can see the stability of the bone, buccally also. One more than the other. Thank you for your attention. Now I will go into the last part, which is recession on implants. Okay? And with that, I will be finished for my lecture. Okay? So what time do I finish here? How long do I have? 1 hour. Okay. me give you some hints about recession around implants, because I learned the hard way. Usually I don't do open flaps, everything is tunneled. But before we start, let me try to train your eye and decide what is difficult and what is easy. We came up with an article on the Journal of Perio years ago, and I would like to share the way that we look at the recession around implants. Obviously, we select always the numerosity. The surgical technique is always a tunnel approach, and I like to share the benefits of doing it that way. This classification we came out with is much easier than the one from Zucchelli, which has 11 varieties. Here we have only 3 varieties. Okay. And I have shown you before, if the papilla are okay, and you have a recession only on the buccal, it's a rather easy case. Okay. The problem is when you don't have papilla heights, then you have a situation where you haven't lost on the buccal, but also in the interproximal, and usually you have lost the bone on the adjacent tooth to the implant, which is a bigger problem. It's what we call type 3, is a bilateral problem. So we have 3 types. We have a buccal recession, type 1, easy one, because all the interproximal is perfect. Type 2 and type 3 have an interproximal problem. It can be unilateral, meaning only one of the papillas is missing. Type 3, only both papillas are missing, which is more difficult. In type 2 and type 3, maybe you'll have to think about some sort of restoration of the adjacent teeth, maybe some orthodontics to bring back the soft tissue. It's up to your knowledge, dexterity, and of a multidisciplinary approach you handle it at your clinic. Okay? But the most important before you are going to do the connective tissue is to evaluate the implant you have to face and decide if it's worth it to graft it. And there are 2 things that you have to learn. One is depth, and the second one is the angulation. The depth is the biggest problem because sometimes the implant is not deep enough. If you are using a 2-piece implant, more level implant, you need at least from the desired gingival margin to the implant head at least 3 millimeters. So if you don't have 3 millimeters, that means that the implant is not deep enough into the bone. You have a problem, you don't have space to guarantee and to improve the soft tissue coronal. So most probably I will extract this implant, because there is no space for you to graft. And then the other interesting approach is the angulation. The angulation of an implant, if you want to know which type of angulation you are facing in your case, one of my biggest advice is try to divide the tooth, the facial tooth, in thirds. So you have the incisal third, the middle third, the gingival third. If your implant is coming out in the gingival third, you have between 20 to 25 degrees of angulation. So it's easy to compensate. If your angulation is coming on the gingival third, it's above 30 degrees, you have a problem. Then depth becomes even more important because it's impossible if you go directly to the implant head to compensate for 30 degrees angulation, unless you use a transmucosal. But if you use a transmucosal, then lingually the implant has to be correctly placed, and then depth is another issue because you need to at least have 3 millimeters of tissue height to really be able to mask that transmucosal if you ever are thinking of doing that. So no matter what you do, if you are coming out on the gingival third, you have a problem. So let me show you a few examples in this article. This is a tissue level implant, we Straumann, and the implant is too far coronal, it's not deep enough, there is no space for grafting, and then it's really close to the adjacent tooth. So I replace an implant, I did some orthodontics, and this is finished. So we extracted the implant. What about this one? You can see the merges profile of the tooth is above the merges profile of the tooth. So you are above the gingival third. So it's impossible for you. You are outside of the boundaries of the central incisors, so it's impossible to restore this case. You're better off extracting. So let me show you different situations, different cases. Type 1 is only vocal. This is a case of mine. This is another case of mine that I have shown you where I have lost the distal papilla on the central incisor in between the lateral and central. This is another case that I inherit, and we have papilla loss in between the central incisor. This is the implant, this is the lateral incisor, which is the tooth, and this is the way that we finished. Okay. So I'd like to share with you some problems, some issues, and some details you have to think before you proceed into your surgery in order to get the best outcome. And the most important is that tuberosity is the most important tissue to graft from, or either retromolar palate. The hard palate is the last tissue I will take from, and is when I don't have any more tuberosity or retromolar palate, I will go to the palate to go back and graft again. Okay. So tuberosity is the essence of pregnancy. And then the most crustal you can graft, the better. And you can see that this is something that you should remember always. The more you graft crustal, the more your prosthodontist will be able to do a good job. So let me show you the problems. Okay? This is a case of mine, 1999. I just came from the States, and the doctor of my city needs a single tooth implant. If I show you this picture, which one is the implant? Difficult to say. Which one is the implant? Everybody knows which one is it. This is me. Okay. And I did this on the doctor of my city. I'm from a small village close to the capital, San Sebastian, 20,000 inhabitants. And every time I was seeing the doctor coming to me, I was changing on the other side of the sidewalk because I was ashamed. I was ashamed to see her mouth. And then I was sending to friends of mine, which were periodontists trained in the States. Hey, what do you do here? Iñaki, don't touch it. Fuck, have to do something, you know. 1998, 1999, just placing an immediate implant was a success. But I couldn't live with this. It was just a problem. And then I just kept it. Please notice that this is an ideal case. If you forget about this one and just look at this one, this is the best single tooth implant you can do. Flat scallop, thick biotype, thick phenotype. Why? Because the flatter the scallop, usually the thicker the bone, the thicker the tissue. Ideal situation. The higher the scallop, the thinner the phenotype, normally the thinner the buccal bone, more difficult. Please watch what happened from 1999 to 2009. This tissue around the implant becomes what? Mucosa. You blow, the tissue does. All the gingiva, the gravitous tissue is gone. Because under function, the tissue transforms around implants. It's a matter of time. Okay. And in some, more than in others. She's a class 3, so this tooth gets a lot of load. It doesn't extend as much as time goes. If you look at your CBCT, look this piece of thickness of tissue is more than 1 millimeter. It's just not normal. Usually you have less than 1 millimeter. And in implants, you have always the two same problems. One is that the tissue transforms into mucosal characteristics, and two is the implant position. And if you place it facially, the bone will resorb, the tissue will resorb to, and you will be able to see even the color of your implant. So if you look at your height and you look at your angulation, I was a rookie. I didn't know what I was doing. The implant is way too facial. And under load, we have a catastrophe. So can we improve the situation? Well, I can tell you right now here that I took way too many implants out. This is possible to restore it. Why? Because the angulation is not so bad. It's within, between the middle third and the gingival third. It's just in between. It's about almost 29 to 30 degrees. And it's a cement retained restoration. So there are sentences which, in the literature, which pushes you to do things that are wrong. And this is one of them, by Chen. Biotype has less impact on tissue stability than implant position. Yes, but it's not true. If you graft, you can improve it. So the idea here is always to graft your implant with connective tissue, and you will be able to bypass many of angulation problems. And the second one is that the tissue becomes mucosal in long term. So that's why connective tissue is mandatory. So finally, I did connective tissue graft. My good friend Grunder, he was hating me. Why? Because he's a born believer. And I have many arguments with him because I said that bone for me is not an issue. Just to put the implant. What I need is volume of tissue to make something natural. So usually when I have a recession, a buccal recession, I elevate the flap, I elevate the papillas, and I grasp around the tooth without removing the crown. And those are the typical situations where I only have a buccal recession, like in this case. So here this tissue is quite thick. I fill it out, but please notice that these papillas are not cutted, they are elevated. They are cutted vertically with ophthalmic blades. We go usually 1 tooth and a half, 1 tooth and a half sideways. Here I cut the papilla in order to bring the soft tissue towards the central incisor. Sometimes through the scallop of the central incisor you are able to glide your connective tissue, and we suture the connective tissue with a sling suture around the implant, and then we pull the flap on top of it. So we create a concavity, and it is 15 years later. You can see the soft tissue, you can see all the flap design, partial thickness. I bonded with cyanoacrylate. This is the healing 15 days, and this is the final result. So type 1 is relatively easy. If you look at Reno Burkhardt, in his paper, he tells you that the coverage of implant is not predictable. And if you look at his article, he opens a flap on an implant. So there are not too many people in the world that open the flap the same than on the tooth and have papillas. So I think the right decision is to use it tunnel. You cannot cut this papilla. You need to elevate it. Okay? Both sides, tunnel it, which is not easy, in order to avoid those problems. All the cases you're going to see, they are not periimplantitis, it's more mucositis, and means that there is inflammation for poor hygiene. I use erbium yak and to clean the sides before I do the surgery, so everything is prepared in advance. And the more I want to create a traction vertically, sometimes I do a semilunar incision. This is from the brothers from Dallas, the Salama brothers. You don't need to do that. Usually I create a concavity, a class 5, and what I do is I elevate, sometimes the thinner the tissue, the more full thickness, I elevate the tissue, I scratch all the tissue. I don't, if you are pretending to do everything from the margin, you will destroy the gingival margin. So that's why I always make small incisions, like vista incisions, to really be able to control in a better way the flap elevation. These are all cases. The soft tissue is first sutured in place. It has been dipped into Endogain. You will see my videos in a moment. I suture this against the tooth, and then I suture the flap on top of it. So I glide the soft tissue, I position it, and once everything has been sutured, then I serrate it with Endogain or hyaluronic acid, all our cases. Okay? So this is where we started, same crown. This is about 7 days, this is 6 months, this is 1 year and a half. This is the iPhone video showing 1 year and a half later. So let me show you this one, type 2. That means unilateral PMLD, perimucosal marginal defect. This was done in Geneva, in Switzerland. So even in Switzerland, they do shitty work. Okay? Because the Swiss, they think that they are above the rest of the people in the world. So this was done in Geneva on an engineer, a Spanish engineer, on the automotive. She was working for BMW. And she was shopping around Spain to see who was presenting her the best option to restore back her aesthetics. So if you look at the case, the first thing you have to ask yourself is this implant restorable? Is this position restorable? You can see that this implant is restorable, is palatally displaced, so we can restore it. It's a bullet of 5 by 16, replace select. Most probably is an immediate implant placement, which is hitting the lateral incisor, just roughly touching the medial aspect of the root. So we have no bleeding on the implant. We have, of course, interproximal bone loss, lack of distal papilla, no buccal tissue volume, minimum keratinized tissue, close proximity of the root to the implant, mesial angulation of the lateral, and we have a diastema between both central incisors. Okay? So you can see that everything that we have in here is mucosal. We have a scar here. You can see the close proximity of the tooth is almost 1 millimeter or less. We cannot grind the implant because the connection is just right there. So it's a big problem. So what would you do? Well, I'm going to show you what I did. I work with an orthodontist in Barcelona. She lives between Geneva, Switzerland, Munich, and Barcelona. And I told her I need an orthodontist to really be able to improve the situation. And this orthodontist needs to work under my rules. Okay? So the way that I was taught, and I have the privilege to learn from one of the masters in orthodontics in the world who passed away, Vince Cockich. The way that I learned is that we always prepare with orthodontics before the surgery. And actually, I learned the hard way, and I do it the opposite of what I have learned. And I will show you why. So the first thing I'm going to do is I'm going to do a first connective tissue on the implant. implant. I want to improve crustally as much as possible. And once I have bypassed the first problem, which is improve crustally my connective tissue graft, I'm going to ask my orthodontist to upright distally my lateral incisor. Meaning I want to take my root away from the implant as much as possible. So I will ask him, listen, maybe I need a minimum 1.5 millimeters away from the implant. If we don't have space, you're going to do a stripping, but where are you going to do the stripping? Distal of the canine. Because if you strip such a small tooth, it will be like a rice. But please, when you upright, I'd rather have the tooth intruded, never extrude the lateral incisor. So once he upright the tooth, I'm going to do the second connective tissue graft in order to improve the soft tissue mesoderm. And then I will place a provisional on top of the implant, and he will use the anchorage of the implant to do the extrusion and recapture the provision, the height of the papilla. The orthodontics is done after the surgery. Why is that? Because everybody assumes that you will have 100% success on the surgery. So if you make extrusion first, and then you do the surgery and you fail, you are dead. You lost the beauty of the game, which is the orthodontist cannot pull anymore because he already did extrusion. So you're dead. So I never do, or almost never do, any orthodontic treatment before the surgery. I always do it after I have done the surgery and I have succeeded with my surgery. Because then he can help me. The orthodontist is the best surgeon in the world. He can place papilla back where it belongs. So let me show you on slides what we did. The first thing you have is the big problem. And the big problem is because this implant is huge. It's a 5 millimeter diameter, and you will see why is a problem. So on the lathe, I reduce it and make a slim abutment, just enough to really be able to unscrew the thin abutment. So you have tons of space to graft crustally. So you can see that the bone here we did the first connective tissue graft. Then we pried the tooth. We left around 1.5 millimeters, and then we finished the case. So you can see that the most difficult part of this surgery is to elevate this little piece of tissue without breaking it. So you sweat quite a bit. I cut the papilla, both papillas, in order to glide my soft tissue into the side and be able, without trauma, elevate the papilla and graft buccolingually, trying to measure the mesiodistal width and trying to support the papillas and reach lap depth. The papillas here are elevated, just to allow this tissue to horizontally, non-vertical releasing incisions, to really allow me to place the connective tissue on a split thickness flap and place the connective tissue vertically where you want it. see the implant is in there, then I glide it below the tunnel, then once I have glided, I suture it to the buccal and palatal flap, then make an incision in the center and place my slim healing abutment. So everything looks like this. This is the soft tissue. Why I cut this papilla? Why I cut this papilla and why I elevate this papilla is because the amount of volume here was much less than the amount of volume on the medial aspect or the distal aspect of the implant. So you can see everything that is above the flap is mucosa. There is no keratinization of the soft tissue. This is how it looks like 2 weeks after. And then 3 months later, I wait. I bonded the provisional restoration with resting on top of the hidden abutment and bonded to the adjacent tooth. I create the diastema, and then I will tell my orthodontist, please upright it and intrude it. So if he intrudes, it's easier for me to graft this recession, and it's easier to graft my implant in the second time and improve the papilla in the medial aspect. So there are many little tricks that your orthodontics can help you to maximize your surgery. The biggest problem here that we are facing surgically is that you have an implant that is huge. You see, you write it, he sent me an email, a WhatsApp, and then, yes, send her over, let's do the second connective tissue graft. The problem in this second connective tissue graft is I cannot remove the healing abutment. Because if I remove the healing abutment, I break all the connective tissue that I have done previously. That's why every time you have wide implant, it's a problem. Because you have to glide the connective tissue without removing the healing abutment. And then we need the trouser. So basically, the trouser is being sutured the mesial, the distal, and the palatal, and the buccal. Okay? So the trouser goes like this. It's being sutured in the corners, and this piece on the buccal is inserted and is moved laterally to graft on the buccal aspect on the lateral incisor and being able to is sutured also to the adjacent teeth. You can see here, you can see here. So it goes against the teeth in order to improve the papilla. So every time you have a wider implant diameter, the more you need to keep the abutment in place, because if not, you will tear it. Then it becomes more difficult. You pray, everything comes beautiful, and you can see now it's a matter of waiting 3 months, placing your provisional abutment. How do you remove this abutment? Well, we make an incision. I will never place this incision here. Why? Because this is where I have the shorter papilla. This is where I've been working that papilla. So I will go on the side where I have bone. I will go on the side where I have less chances to tear this papilla that I've been working on during all these months. So So I make an incision with a blade and I gently pull this healing abutment vertically, tearing the tissue and taking an impression and doing a provisional restoration. With this provisional restoration, what he does, he extrudes the lateral incisor until he levels the papilla height. We cut the incisal edge and we improve the papilla. We modify the soft tissue, crystalline, and we finish it. This same situation, you can see that the tissue here, the amount of elastin of the grafted tissue modified the overlying flap and had all keratinized mucosa. So we're lucky. I don't know why we didn't do a screw retain restoration, but we did the cement retain restoration. And this is the finished case, cordial buccal, cordial palatal. And this is the day that we deliver. The case will be the composite of the central incisor. This is the day of the delivery with my iPhone. This is where we started, where we finished the day of the delivery. This is 2.5 years later. So I didn't see the patient for 2.5 years. So we modify the tissue a little bit and finalize the case. We cleaned it. This is how it looks like. Everything is splinted. So we polished a little bit our. You can see everything is splinted and finally 3 years now. Same. So for me, using healing abutment, the smallest as possible is important because it really allows you to graft crystalline. So this is type 2 DMMD. We have lost the distal patient has an implant. She doesn't like it because she has a dark hole. She has 2 crowns that she doesn't like. She has a natural tooth on the central incisor and an implant where she has lost the distal papilla. So this incision, I always make an incision crystally. And in this case, we're going to invert all the soft tissue. We're going to make a small incision, and from the tip, from the top, we're going to elevate full thickness the flap as much as possible. We're going to make a vertical releasing incision on the median, another one on the distal, and another one on the base. And then we're going to start brushing and pulling the tissue down. We're going to see the mobility of the papilla. We're going to also elevate the palatal tissue in order to allocate the connective tissue where you want it. And then we're going to suture crustally our connective tissue. We have long needles, so we're going to take the tissue from the tuberosity, and we're going to suture it crustally, and then with the laser, I'm going to bring the higher quantity of tissue towards the median because I want the bigger amount of tissue on the median. And I'm going also to graft interproximally and locally the tooth. So I have a bigger amount of soft tissue possible with the sling suture on the adjacent tooth to plant up. And then I'm going to push all the tissue, palatal and buccal, and buccal tooth to go around the tooth and to pull all that tissue down. Okay. So this looks this way. This is 2 weeks down the road. This is the provisional restoration. But 3 months later, you can see that the tissue crept back. I don't have enough palatal tissue, so I decided to do a second round of connective tissue grafting. This is the scenario, and I decided to graft again. So I don't have the video, but I placed a bigger piece, and this is the healing. This is the amount of soft tissue. You can see how much we removed on my provisional restoration to allocate the connective tissue. And now, little by little, every 10 days, I'm going to be adding acrylic to a point where this tissue will come down. So we always push interproximally, and then at the end we push vertically. It looks something like that. This is where we started. This is a veneer, and this is the provisional restoration. I did the composite here. And now we have a problem because we have to reconstruct an implant next to a crown. So we know that this crown is going to move. So how do you do it? Well, let me share with you. This is the situation. We have the volume now. Now it's a matter of how I'm going to restore those two guys. This is the situation. So this is the implant. The implant is, I don't remember the brand. We have more than 2,000 brands in Spain. And here we did the zirconia abutment bonded into a titanium prefabricated abutment. So I did first the titanium abutment, and then what I did is a copy on top of the tooth. The finishing line is quite deeper than normal. And then what we're going to do is I'm going to bond the splinted crowns on top of my implant. And I'm going, once I have bonded my implant, then I'm going to reline with composite. I do a venting hole in order to have a precise adaptation of my crown with a nice, perfect adaptation of my implant. So there is no food impaction in between. Usually it is cemented with resin phosphate cement and Vaseline. So if I ever want to take it out, the coping will stay bonded to the tooth, and I will be able to maybe clean the implant if I have any problem. But in this way, the tooth won't move, it won't extrude, and will stay perfectly in place. Those are the different situations with the X-ray. First I do the copy on the tooth, and then I take an impression of how much I create the pressure to push the tissue down. I transfer this information into my titanium abutment where I bond the zirconia on top of the abutment, because you can have, depending on how you bond it, you can have a variation. And then what I do is I take a final impression of both teeth to reconstruct the prosthetics that goes on top of my copy and bond it into my zirconia. So not easy, and this looks something like that. This is the final result. The veneer on top of the lateral incisor, and both central incisors are splinted. one on top of copy, and the other one goes directly to the implant. And you can see that I decrease the volume of the papilla. This is few years down the road, a year down the road, you can see how the tissue has grown and how it looks like clinical. So let's look at different other cases, more complex. We're going to show a type 3. This is an interesting case where the lateral incisors are canines and the implants are placed on the canines. So there is an agenesia of lateral incisors, but you see that this patient has many problems. He wanted veneers. I said you're better off doing orthodontics to do just a composite. I wouldn't do veneers on you. I want to do a crestal connective tissue and crown lengthening. I want to do some crowns. So I wanted to first show it to him. I did a mock-up. I said, this is what I'm thinking of you. But I would love to not touch your teeth, do crown lengthening, improve the volume of the soft tissues, improve the papilla height, which is missing on both sides. And so he's having prostheses that are not fitting well. We did the crown lengthening. And then once he finished the orthodontics, you can see once I did the crown lengthening, what you can see is that I reduced the diameter of the root. Compared from here to here, the problem is you cannot touch the interproximal bone because if not, you will lose papilla height. And then we graft at the same time. We did some bleaching on him. So you can see that this bleaching, this is the provisional. We used some composites on his own ceramic crowns, and then we took impression. We did some provisionals. You can see it here. Did the composite with the crack. Finalize the case. This is the provisional restoration. So you can see how the tissue is coming back little by little. We have a nice emergence profile with nice papillas, narrower tooth, allowing more space for that tissue to grow. So this is what it looks like. This is the finished case. And you can see papilla, implant, crown, lateral incisor on top of the canine, composite, where we started and where we finished. Orthodontics, another case, the problem is when you don't know the origin of the implant. See, the more you keep the abutment that the patient is wearing, the more you are limiting the amount of grafting you are able to perform between the teeth. So this is a difficult case because we are going to keep the abutment because the patient, the dentist died, so we don't know which is the type of implant they use. They keep the abutment. So keeping the abutment limits the amount of soft tissue grafting you can perform crestal grafting. So I place a provisional restoration, and then what I did is I made the vista incision. I elevate all the flap buccal and palatal, and and I grafted lingually in between the central incisor and the implant. And I did a reduction of the root in order to allocate and create more space. Usually, I always like to have, this is the before, and this is the after. I always like to create a really thin finishing line of my prep, so my technician knows how deep it needs to go. This is a second provisional restoration, 2 weeks later. Tissue is coming back little by little. And then something that I learned by myself is the depth of my finishing lines. They are at the same level with the proximally, so my technician has a control about the emergence profile. I tell him I want just the zirconia in the bottom. So if he has the same leveling, he has an idea about the total contour, how he needs to support the soft tissue not only vertically but also horizontally. And this is something really important to create for them, so they know how much they have to create, how much space they have, and how much space they need to create in order for that tissue to grip back. So the emergence is the same based on the amount of space you have in between. Okay. This is the day of the delivery. Of course, the soft tissue is resorbed because we have been moving it day in and day out. But as we see the patient 3 months later, you can see how the tissue is creeping back and how the tissue is improving. And this is the iPhone video with papillas almost to the place. Okay. So, how much do I have? 5 minutes, 10 minutes. So I will jump in something that maybe you have never seen before. Just one little quick thing. Whenever you have an implant with an external hex, usually I get rid of this hollowed part. So basically, the screws just fits the hexagon, okay? And so it looks like this. This is a little video showing how we do it. If I place this is a 3i hidden abutment, 5 millimeters high. If both goes in the same direction, what happens? Goes away. So one goes forward and the other one goes backwards. And then in this way, you will be able to reduce the diameter. And in one point in time, you will see that you will create a space here. And here, the space will debond from the rest. You can see that the ring will come out at the moment. The ring is coming out. Okay. So you take all that ring off. What you want is to have the perfect fit. So you will little by little polish it. This can be done by the technician, by your technician. You know how to do it. But usually on drug-mark implants or external hex implants, we get rid of that hole in them. Okay. This is how it looks like. This is another implant. We did a connective tissue graft. case, and then I will be done for this course. Okay? This is an extremely difficult case. It is one of the most difficult cases I have to confront. The patient just had the crowns done by another dentist, and of course she's not happy. She got two implants on both lateral incisors, and one is about 6 millimeters palatally. See here, trauma implant, and this one is much better placed. So here what we are going to try is to fill with connective tissue all these black areas. So here we have a bigger problem in this side because it's a vertical and horizontal component. If I'm not able to perform and to fill all that tissue, maybe what I can do is maybe do some sort of crown lengthening on the central incisors that are touch erupted and leveling the soft tissue. You can see all the planning, and I asked my technician Yoshi, please make two Maryland composite teeth, and please wax how much tissue I have to gain vertically and horizontally, which is a lot, especially on this side. The problem with Straumann is the highest healing abutment is 5 millimeters, which is a pity because here the implant is about 10 millimeter deep. So the first surgery, this is number 12. I make 3 vista. Usually I modify my blades, so they only cut in the base, and I make vertical and horizontal releasing incision. And through those holes, what I'm going to do is I'm going to elevate my flap, and the connective tissue is going to be grafted. The thicker one is going to be grafted on the bridge, and then these wings are going to be grafted on the adjacent teeth in order to maintain verticality and horizontality. So I will go through these holes because it's impossible to go through my implant hole because I will tear my papilla, and it will be reflected from the vertical releasing incision, the vista technique. Then I will make a hole and place and suture around my teeth. And then once I have done one side, I go to the other side and perform the same. Number 22 is easier because the tooth is centered, the volume is easier to place and to adapt. And this, once we finish, I take my impression. This is the surgery. I don't have time to show it to you because this is how it looks like when it's done. So you can see that we grafted. You can see how much we pull all the mucosa down. This is day 0. This is 1 week. I wish it would have stayed like that. This is 2 weeks. This is 3 months. So you can see here is finished. This guy is don't have gingiva, or it's mucosa, I still need soft tissue. The bigger problem here is that the implant is far back. I don't have a palatal wall. The more we are missing the palatal wall, the more it's difficult to improve your vocal soft tissue. So in this case, I'm pretty much done on number 22. But here what I want is to create a volume on the palatal aspect. The only way to create volume on the palatal aspect is to create a pedicle. The implant is totally inclined, palato-buccal. This is my situation. So I want to increase as much height of tissue on the palate to bring it forward and have a papilla. Okay? So I'm not having soft tissue in the palatal aspect. I don't have a vertical wall to come up with that. So how I can create a vertical wall of tissue is doing a pedicle connective tissue graft. A subepithelial connective pedicle tissue graft. So what I did is the problem is this tissue is the poorer tissue. Normally what I do is I like to take the superficial and go underneath. You will see it how. If I leave this little step here, is a partial thickness, is a full thickness, and then this tissue is elevated and is going below this part which has been elevated. So this tissue will go underneath the tunnel and will be divided into and will be sutured in the mesial of the distal and in the mesial of the tooth in order to provide height. So you can see how the tissue, the problem is this tissue here is the most glandular, is the poorer soft tissue, and the tissue is being nourished by this pedicle here. So you need to be really careful how to do it. I'd rather do this. So basically, this is the lamina propria. What you see in there is the submucosa. There is another case where we took the superficial connective tissue, which has more lamina, denser soft tissue to graft from. That's from another case, the one you have seen before. And what we were able to create, provide, and finish. Okay. So coming back to my case, I bring the soft tissue underneath to bring as much height as possible on the back. Not happy with the amount of soft tissue I had, I took it from the other side and suture it on the buccal aspect, on the buccal from the implant. This is the video of the surgery. It's a long video. You can see a little bit the details of how careful we are elevating the soft tissue, creating an incision to really be able to create a tunnel on the ridge. Usually I cut it, half the thickness of it, to really be able to pull the tissue down as much as possible. Now I have to go to the palatal aspect and mobilize my flap. You can see I have cut my papilla in between both teeth to have more mobility. I remove my clean abutment from previous surgery, and then I elevate the palatal aspect, and then I use this stent that goes all the way up to the first molar to do my pedicle, to elevate carefully my soft tissue. You can see it here. I suture it so you can see. I then make a second incision 3 millimeters away from the first one, so my tissue can rest on that step, and they will have less necrosis. So I will go deeper on the palate and just elevate the soft tissue. You can see that all the soft tissue I'm taking it from the palate is rather glandular. You can see it here in a minute. And what I will do is I will bring it over the buccal and divide it in two, but it has to go underneath my crestal soft tissue. Okay, so it has to go underneath this muscle. So it has to go like that. So I will suture. I will come up from the middle, I will come up from the distal, the mesial, and I will pull it from 3 areas, mesial, distal. So I have another hands of another, I always put some liquid to glide the tissue and to push the tissue vertically. So I'm pulling, and then the tissue is going through it and improving the distal part. You can see a blood on the palatal aspect. The tissue is now almost over. You need to be careful not to tear all the tissue that is on the crest. I close palatal, and then I take my soft tissue, I clean it, I put my end again, and I look for my tissue, I take it out, I take all the suturing, to have an idea how is the position of my soft tissue. I divide it in two. One will be sutured on top of my canine. The other one will be sutured